Well, I want to welcome everyone who came here. I know that getting into downtown Boston at the beginning of the rush hour is often a challenge, so I anticipate we'll probably double in number by the time the presentations and discussion are underway. In any case, I'm very, very delighted to welcome an old friend of the prep program, Judy Foreman, who we were trying to recall when Judy gave her first talk, because she's had an interest in pain, and as an eminent health journalist, has been someone that people want to hear from and have the perspective from about her own views on pain. But something very exciting happened a few years ago. Judy decided that she would write a book on pain, and this book is now complete. It's being co-published by Oxford University Press and the International Association for the Study of Pain. And I think it will be a blockbuster book. Judy is just absolutely first-class journalist. And then we were also very fortunate to have a couple of people who have different perspectives that are, I'd say, complementary to Judy's, join us as panelists. And you'll hear more about them later, but I'll just mention that they are Barbara Kivowitz, who is a senior partner in IM21. It's a consulting and analytic firm that helps organizations work better together. She's also on the board of Harvard Vanguard Health System. And Zahid Bajwa, who's a clinical neurologist, also board certified in pain medicine and headache therapy, who has been involved in clinical practice and pain education for 20 years. I'm actually holding Barbara's new book, which is called In Sickness as in Health. I don't want to steal her thunder, but basically she explores a dimension that is often underexplored, namely the impact of chronic illness, including chronic pain, upon relationships. And I salute Richard Weisberg for being here as the other half of that relationship, principal relationship. So without further ado, there's much, much more I could say about Judy, who's just spectacular level of energy, swims at the world-class level in swimming competitions, sings, is, I don't know, maybe I got the details right, you're developing a new theory of the universe, your astrophysics
course. No.
But at least to make us less afraid. She's not teaching the astrophysics course. She's just taking the astrophysics course. So I'm going to turn this over to you, Judy, and thank you very much for coming.
Okay. Oh, thank you. Hold your applause. So as Dan said, I'm writing this book on pain, and I always forget to mention that there was a reason for this, which is that I ended up with excruciating neck pain about 4 or 5 years ago. And, you know, I'd been a medical writer at the Globe for my whole life, basically, and had written some about pain, but I was dumbfounded when it happened to me. At midnight, my neck would be killing me, and I think, why would evolution have, come up with this? It makes no sense. It's not adaptive. And like every other pain patient I've ever heard of or talked to, I didn't get treated all that well by the medical establishment. I got told it was all in my head. There was nothing they could do. It was really eye-opening, and I ended up writing a column for the Globe about my experience and got a deluge of emails from people with similar experiences and decided maybe there was a book in this. Anyway, it is a book, or soon to be a book, and the whole process has been a really radicalizing experience for me. I've talked to more than 200 doctors and scientists, a couple of lawyers, and a lot of patients, and I've come away believing that it's outrageous that pain is still so ill understood and still so undertreated. That's especially the case because chronic pain is actually a bigger problem than heart disease, diabetes, and cancer all combined. It is the leading reason that people go to doctors, and it is an enormous problem, much bigger than most people realize. In June of 2011, the Institute of Medicine, which most of you know about, it's an arm of the National Academy of Sciences, came out with a blockbuster report on pain, and they found that there are 100 million American adults in chronic pain. Not all of them are in severe disabling pain, but some pain experts estimate that maybe a third are, which would be 30 million people. And the rest are bothered to one degree or another by pain. And this 100 million figure does not include kids, does not include people in the military, and does not include people in institutions. So if anything, this is very likely to be an underestimate And in this talk and in my book, I focus mainly on chronic pain.
Pain's
not
one
acute.
thing. Most people experience pain in their lifetime. Chronic pain, though, is a whole different animal. So for those of us that have had that and then get relief from it, it does. It gives us back our ability to really enjoy a lot of life. And it's wonderful. It's like it's a wonderful gift. Well, we always talk about pain on a scale of 1 to 10. And mine was resonating at the top for a very, very long time. 10 was not unusual.
And a lot of people dismiss chronic pain saying, it's not fatal, but it can be. The suicide risk for people with chronic pain is twice that of normal people. If you're in unrelenting pain and no one's doing anything about it, you do end up often feeling hopeless. This is one of my favorite patients whom I interviewed. He's a truck driver from Salt Lake City. His name is Hiram Nizer, and he would be dead today if his wife hadn't walked in on him with a gun in his mouth. He was literally on the edge of suicide. He had excruciating headaches. He had been to hospital after hospital, this is Salt Lake City, and nobody worked him up, and they all assumed he was drug seeking, which is a really common experience for chronic pain patients. They had him so convinced that he was a narcotic abuser, narcotic is sort of the old word for opioids, that he ended up in a Narcotics Anonymous meeting and institutionalized in a psychiatric hospital. And he'd be sitting in these therapy groups with the real drug addicts, and they'd be saying things like, I'd sell my kidney for OxyContin, I'd rob CVS for drugs, and he was saying, this is not me. All I want to do is get rid of my pain. And nobody would take him seriously. Finally, one night he did go to a hospital where they did work him up. He had 2 brain aneurysms, and one got operated on that night, the next one a few months later, and this was pain that could have been treated when he first had it. He still has a fair amount of chronic pain. He's being managed by one of the country's best pain doctors, Perry Fine, in Utah, and he's still on opioids because of the problems left over from surgery. But his case just totally got to me. The nicest man. He almost lost his home. He almost lost his marriage. He did lose his work, everything because of chronic pain. And chronic pain is not just a horrible medical problem. It's a huge economic problem as well. The Institute of Medicine report that I just told you about, they were mostly doctors and a few nurses and scientists on the panel, but they wanted to figure out what the economic impact of pain was. So they hired a couple of health economists who ran the numbers and put together as best they could. I mean, economics is impossible. But they came up with this estimate that chronic pain costs this country as much as $635 billion with a B every year. That's a lot of money. And it's an ill-understood problem. So what is it? Chronic pain or pain, this is sort of the basic pain pathway. And I will tell you in a little while how acute pain becomes chronic pain. But basically, as you can see from this animation, a lot of times pain can start with an injury or an inflammation or something in the periphery, goes through various nerve fibers, up through the spinal cord into the brain, where, as you can see, it spreads out. And one of the key things is that pain is not just a sensory experience. It's not just incoming firings of nerves. It goes to parts of the brain that deal with emotions, too. There's no way to have extreme pain and be la-di-da about it. I mean, it is an emotional experience as well as a sensory experience. And I want to show you this short video because this is such an eloquent slide coming up in a second. But first, the official definition I wanted to get out there is from the IASP, which is one of my co-publishers. And it's pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And, a lot of people spend a lot of time coming up with this definition. And the emerging view of chronic pain is that it is a disease in itself. This guy is one of the really brilliant pain researchers. He happens to be in Boston at Children's Hospital now. Is Clifford Wolf. And he says there's been a shift in our thinking away from pain as only a sensory experience. Chronic pain is not just a symptom of something else. It's a disease of the nervous system. And this insight really does change how we view pain. And this is really important because doctors are always thinking, well, what's causing the pain? And that's a reasonable question, but it can become its own disease in its own right, as you will see right
I'm
now.
a pediatrician and an anesthesiologist, so I put children to sleep for a living. And I'm an academic, so I put audiences to sleep for free. But what I actually mostly do is I manage the pain management service at the Packard Children's Hospital up at Stanford in Palo Alto. And it's from the experience of about 20 or 25 years of doing that I want to bring to you the message this morning that pain is a disease. Now, most of the time you think of pain as a symptom of a disease, and that's true most of the time. It's the symptom of a tumor or an infection or an inflammation or an operation. But about 10% of the time, after the patient has recovered from one of those events, pain persists. It persists for months and oftentimes for years. And when that happens, it is its own disease. And before I tell you about how it is that we think that happens and what we can do about it, I want to show you how it feels for my patients. So imagine, if you will, that I'm stroking your arm with this feather, as I'm stroking my arm right now. Now I want you to imagine that I'm stroking it with this. Please keep your seat. A very different feeling. Now, what does it have to do with chronic pain? Imagine, if you will, these two ideas together. Imagine what your life would be like if I were to stroke it with this feather, but your brain was telling you that this is what you are feeling. And that is the experience of my patients with chronic pain.
In fact, chronic pain is now known to change the brain. You actually lose brain volume with chronic pain. The picture on the right is Vanya Apkarian. He's at Northwestern. He's one of the leading pain researchers. And he found in a study that was first published, in 2004, that he was studying people with chronic back pain, they have 5 to 11% less gray matter in their brains than healthy people without pain. And this was the first time that this has been shown that brain loss can actually be a problem that happens with chronic pain. He was the first to discover it with chronic back pain, but since then other people have found it in fibromyalgia, irritable bowel, tension headaches, and a lot of other syndromes. And the amount of brain loss that he found with these people with back pain is equivalent to 20 years of aging. So chronic pain literally can age the brain. The good news is that there's been some recent studies in England showing that if you can get rid of the pain, like people with hip replacements, when the pain actually is made to go away, the brain can revert back to a healthier state. But it's really, nobody knew until fairly recently what a big change it made in the brain. And this is why we're going back to Elliot Crane.
That was the experience of my patient Chandler, whom you see in the photograph. As you can see, she's a beautiful young woman. She was 16 years old last year when I met her, and she aspired to be a professional dancer. And during the course of one of her dance rehearsals, she fell on her outstretched arm and sprained her wrist. Now, you would probably imagine, as she did, that a wrist sprain is a trivial event in a person's life. Wrap it in an ace bandage, take some ibuprofen for a week or two, and that's the end of the story. But in Chandler's case, that was the beginning of the story. This is what her arm looked like when she came to my clinic about 3 months after her sprain. You can see that the arm is discolored, purplish in color. It was cadaverically cold to the touch. The muscles were frozen, paralyzed. Dystonic is how we refer to that. The pain had spread from her wrist to her hands, to her fingertips, from her wrist up to her elbow, almost all the way to her shoulder. But the worst part was not the spontaneous pain that was there 24 hours a day. The worst part was that she had allodynia, the medical term for the phenomenon that I just illustrated with the feather and with the torch. It's successful, as you can see from this video of Chandler, who 2 months after we first met her is now doing a backflip. And I had lunch with her yesterday because she's a college student studying dance at Long Beach here. And she's doing absolutely fantastic. How can the nervous system get this so wrong? How can the nervous system misinterpret an innocent sensation like the touch of a hand and turn it into the malevolent sensation of the touch of the flame. Well, you probably imagine that the nervous system in the body is hardwired like your house. In your house, wires run in the wall from the light switch to a junction box in the ceiling, and from the junction box to the light bulb. And when you turn the switch on, the light goes on, and when you turn the switch off, the light goes off. So people imagine the nervous system is just like that. If you hit your thumb with a hammer, these wires in your arm, that of course we call nerves, transmit the information up to the junction box in the spinal cord, where new wires, new nerves, take the information up to the brain, where you become consciously aware that your thumb is now hurt. But the situation, of course, in the human body is far more complicated than that. Instead of it being the case that that junction box in the spinal cord is just simply where one nerve communicates with the next nerve by releasing these little brown packets of chemical information called neurotransmitters in a linear one-on-one fashion, in fact what happens is that the neurotransmitters spill out in 3 dimensions, laterally, vertically, up and down in the spinal cord, and they start interacting with other adjacent cells. These cells, called glial cells, were once thought to be unimportant structural elements of the spinal cord that did nothing more than hold all the important things together like the nerves. But it turns out the glial cells have a vital role in the modulation, amplification, and in the case of pain, the distortion of sensory experiences. These glial cells become activated, their DNA starts to synthesize new proteins which spill out and interact with adjacent nerves, and they start releasing their neurotransmitters. And those neurotransmitters spill out and activate adjacent glial cells and so on and so forth, until what we have is a positive feedback loop. It's almost as if somebody came into your home and rewired your wall so that the next time you turned on the light switch, the toilet flushed 3 doors down, or your dishwasher went on, or your computer monitor turned off. That's crazy, but that's in fact what happens with chronic pain, and that's why pain becomes its own disease.
This is incredibly important, the business about glial cells, because most doctors, this is fairly new information, but most doctors and most lay people think of pain as purely a nervous system problem. But these glial cells, there's several different types, and one type that's important in pain is actually derived from the immune system. And just as he said, you know, the immune cells that are floating around in the nervous system talk to the nerve cells and rev up the whole process until it becomes like an autonomous runaway train. And, you know, the initial cause of the pain may be long gone, but the system keeps going, rev, rev, rev. And the glial cells have a lot to do with that. This woman is Linda Watkins. She's from Colorado. She's a terrific person. She's basically one of 2 or 3 leaders in glial cell research. And I went and spent 3 days in her lab a couple years ago. And the importance of this whole thing is that if they can really find a way to target drugs to the glial cells, it gives a whole new range of medications so that we'd have to rely less on opioids, which have a lot of their own problems. So it may sound very esoteric, but it's actually very important and has a lot of potential pharmacological value. I included this picture of Albert Einstein to help you have a visual hook to glial cells. There's a wonderful story about Einstein and his glial cells. When he died, I think it was 1955, a pathologist named Thomas Harvey did the autopsy, and then, this is not recommended procedure, but took his brain home and left it in a plastic jar for 40 years in his house. And then the pathologist started getting old, and he contacted Einstein's granddaughter in California, who understandably wanted the brain. So the pathologist put this brain floating around in the jar in the back of his Buick Skylark and drove it across country. And luckily stopped first at UC Berkeley, where he gave parts of the brain to a very renowned neuroanatomist, Marion Diamond, who looked at it and she thought, well, you know, maybe I can figure out what made Einstein so smart compared to the rest of us. And there was only one thing that was different in his brain, which was a huge excess of glial cells. So these little cells, which most of you probably haven't heard of, turn out to be really important, maybe for intelligence, definitely for pain. We don't know if Einstein had any excess pain, but I hope you remember him when you think about glial cells. So now you know a little bit about glial cells, but most doctors don't know the contribution of glial cells to pain. And that's appalling, and there's a very good reason why doctors know so little about pain, and that is because medical schools barely teach it. You may be surprised, or maybe you won't be surprised. I was surprised. Given that pain is the main reason people go to doctors, you would think they would teach it in medical school, but basically they don't. This is Joe Martin, the former dean of Harvard Medical School. I had lunch with him right when I was starting this book project, and I asked him over lunch, so in 4 years of medical school, how many hours do your students get on pain research? Anybody want to guess? Who said 10? That's way too high. I won't tell you because he swore me to secrecy, but it was in the low single digits. And he wouldn't let me quote the exact number, but he did let me quote him as saying, "We do not sufficiently educate students about pain and pain management." The paltry number of hours at Harvard is not exceptional. In fact, there was a very good study from Johns Hopkins in 2011, and they looked at a lot of medical schools, and they found that pain education across the board is limited, variable, and often fragmentary. In fact, when they studied these 117 medical schools, the average number of hours spent teaching students about pain was 9. And that's the main reason people go to doctors. I mean, it's a colossal mismatch. In fact, I dug up some other stories. Veterinary students get at least twice as much education in pain as medical students. This particular citation, not the picture, we found the picture, but this study was from 2009 in Toronto. And it's not the only study that shows veterinary students get more pain education than doctors. Frankly, no one is more surprised by this than doctors themselves. They sort of assume their colleagues know what they're doing with pain, but that is not true. This is Howard Haidt, who used to be a very happily practicing gastroenterologist in Maryland. He was on his way to a big meeting at NIH in Bethesda and got in a horrible car crash, wound up in a wheelchair and in pain 24/7. And he was absolutely stunned by how little his colleagues knew. He said, "It became apparent to me that my fellow physicians had no idea about pain or how to treat it. If this was being thrown at me as a physician, as a male, what is happening to the average person going to the doctor?" I was that average person, and I could tell you it wasn't good. So knowing about his story, I pursued a bunch of other doctors who had obviously accidentally become pain patients. This is David Biro, who's a dermatologist in New York. He had a very rare disease. It was not cancer, but he needed chemotherapy, radiation, and ultimately a bone marrow transplant. The radiation caused such a bad burn on his scrotum that the skin came off. And he told me, I knew that would get your attention, he said he got very little empathy from doctors, and the pain was beyond excruciating. And his conclusion about how the medical system deals with it is, he's told me, we doctors are trained on this medical model. We're not used to going to the next level. What do? We say, go see somebody else, go see a shrink. The problem is the shrinks don't know any more about pain either because they go to the same medical schools as everybody else. There's another scientist, he's actually a pain researcher in Seattle, Mark Cooper, whom I talked to. He had something a little bit similar, I think, to what I had, really horrific neck spasms. And in his case, it was a pinched nerve in his neck. And he actually had one spasm that was so bad that it pulled his whole body way over to the left, and he had to have help getting straightened out. Anyway, he too went to many, many different doctors, and his conclusion was that he was very lucky to actually get diagnosed eventually, but that if he had been a woman or if he had not had a background in neurobiology, he really thinks that what happened to him might have been viewed as psychogenic pain, almost certainly. I have many more examples, and I'll only give you one more. This is Karen Binkley. She's an allergist in Toronto, very athletic, as you can see. She tripped over the elliptical machine that she had in her living room, broke her foot, which, like the girl Chandler you saw in the video, should have been a nothing experience. But she, like Chandler, developed this, she got complex regional pain syndrome, which is, a complicated thing like the young girl Chandler got. And she also traipsed around all of Canada and the northern U.S. trying to find help for her complex regional pain. She's somewhat better now, but not completely. And her conclusion was, it's only because I was a physician that I had the knowledge and resources to help research my care myself. I would have been institutionalized if I had not been a physician and not been so persistent. So this is doctors telling their own story when they become pain patients. Unfortunately, the federal government is no better than medical schools in dealing with all this. In fact, really, it's pathetic. I had lunch out in Colorado with David Bradshaw, who is a pain researcher, and he took it upon himself to study the NIH budget, which was a labor of love and hate. And he analyzed all the data. What I've got in here is through 2009, but it's continuing the same trend. He calculated how much money in the fairly massive NIH budget goes to pain research, and his conclusion was that it's less than 1%. 0.45% of this huge NIH budget goes to pain. Obviously, as a journalist, I couldn't take his word for it. I called NIH, which is, 10 phone calls. And I got their number, which was about 1.3%. And it's actually gone down. It is absurd. This is the biggest reason people go to doctors. It's bigger than cancer, heart disease, and diabetes combined, and it gets way less money. Everybody who knows about pain kind of knows this, but it's sort of like a well-kept secret. This is Phil Pizzo. He's the dean of the Stanford Medical School. He was head of that Institute of Medicine committee that wrote the big report in 2011. And you don't get to be dean of Stanford Medical School by shooting your mouth off, but I asked him, what's going on? Why is pain so underfunded? And he would say this on the record. Because there is no single institute funding pain at NIH, there is not a coordinated allocation. Yet pain costs the nation more than cancer, heart disease, and diabetes together. The funding for pain research is only a fraction of that allocated to these disorders. And I won't bore you with the bureaucracy, but there are two committees, basically, at NIH and the government as a whole that are trying to coordinate pain efforts across agencies. It's pathetic. They have no money. And when I was starting to report the book, they didn't even have a coffee pot. So this is not a major federal effort. All that is a major part of the pain picture, but there's another part as well, which is the reality that we have two colliding epidemics in this country. We have a prescription drug abuse epidemic, which is real and bad, although not as bad in a lot of ways as the press, my brethren, would have you believe. We also have an epidemic of undertreated pain. And these two things exist in practically separate universes. Legitimate pain patients often don't get the opioids they need, and street addicts get them with incredible ease. It's true that overdose deaths have gone up in terms of prescription painkillers, but what's hardly ever mentioned in all the statistics and all the news stories is a lot of those deaths, and there's about 15,000 a year, also involved alcohol or benzodiazepines, and yet opioids, narcotics, get all the blame and all the crackdown from the Drug Enforcement Administration, the police, and state authorities are aimed at opioids. You may not have time to look through the whole thing, but the gist of this slide is that although in the public mind we think that these street addicts are getting their drugs from unscrupulous doctors and pill mills and all sorts of nefarious things, in fact, 70% of prescription drug abusers get their drugs from friends or relatives. My medicine cabinet. My late husband died of prostate cancer 6 or 7 years ago, and it wasn't until I started writing this book that I looked at my medicine cabinet, and it was full of all these painkillers. And I am soon to have adolescent grandchildren, and I thought, holy cow, it's me. The problem is me. And we have a sort of okay take-back system run by the Drug Enforcement Administration, but it's a drop in the bucket compared to the problem. So this is where people are getting their drugs. It's not, the pill mills get the headlines, but the actual reality is that it's from our medicine cabinets. Yet the myth persists that on the left is a legitimate pain patient, my friend from Salt Lake City, Hiram Nizer, who can't get the drugs, goes to a hospital and gets accused of being a drug dealer. Meanwhile, there are legitimate drug dealers who get drugs really easily. But I put this slide up on purpose with an African-American guy as our image of the drug abuser. But here's the real image, Rush Limbaugh, which you probably recognize. So even in Who's the Abuser, we get things very backwards. The other thing that's really important for drug abuse is people really don't understand, including a lot of doctors, the difference between addiction and physical dependence. It's some people quibble about whether this is a real difference, but I'm convinced it really is, and every pain expert that I've talked to has assured me of this. Although this is a highly political thing. There's kind of a right-wing faction of anti-opioid doctors who are gaining some traction in Congress and other places. But in reality, addiction is a real disease. It's a primary chronic neurobiological condition. It's characterized by impaired control over drug use, continued use despite harm, compulsive use, even committing crimes to get the drugs. People often call things addiction when they're not. Real addiction is what I just described. Dependence is different. It's a state of bodily adaptation to the opioids that you're taking in for the pain. And Dan can correct me if this is wrong, but if you take opioids for any period of time, couple of weeks, there's a 100% chance, it is a certainty that you will become dependent. But that's not bad. Many pain patients do become dependent, but they don't up their dose, they don't commit crimes, they don't use the drugs despite harm to themselves. They take them in a very responsible way. It's a totally different thing. I mean, dependence does mean that if you try to get off the drugs too fast or without the help of a doctor who knows what he's doing, and there aren't that many of those, getting off the drugs can be hard. But on the other hand, many people live decades on Vicodin and other drugs and don't abuse them, don't become tolerant, and do get enough pain relief that they can continue with their lives. The actual risk of addiction is hard to pin down. The experts that I talked to think it's about 8 to 10%. The government says it's about, this is real addiction, between 3 and 25%. That's a lot. You certainly don't want to have real addiction. On the other hand, even in the worst case, taking the 25% number, that means that 75% of the people who take it aren't going to get addicted. So my conclusion is we are really overly afraid of opioids. Sorry, I'm having a coughing attack. And opioids, unfortunately, aren't even as effective as we would like to think. They only really reduce pain about 30 to 40%. And it's not clear how long they work long term. There's a big debate about how the long-term efficacy, and basically there's just not enough data on this. So we need more of the studies that do that. On the other hand, it doesn't make sense to take away these drugs from people who have been using them responsibly for many years, which is sort of what's happening. A side point to this, excuse me, is I have a whole chapter on marijuana, and there's some evidence that if you take marijuana along with opioids, there's a good positive synergistic effect, and you can actually take less of the opioids. Unfortunately, that's not the thinking of the government, especially for veterans. If they have a positive urine test for marijuana, their doctors aren't going to want to give them opioids. And in fact, there can be a very potential good synergistic effect. There's many things in the book that I can't talk about today. One of them is genetics. These are two, Clifford Wolf, you met in an earlier slide. Jeff Mogul is a geneticist at McGill, both really good researchers. And they are trying to find out why some people are much more susceptible to pain and chronic pain than others. In fact, the current thinking is that 40 to 50% of our susceptibility to serious chronic pain problems is genetic. And this is from a lot of animal studies and a lot of twin studies, a lot of which Jeff Mogul has done. And I found the pain genetic, I have a whole chapter on the genetics. It's really fascinating. One of the main genes that seems to be, there's like a dozen genes that are kind of like the leading candidates for what's going on genetically for people who are susceptible to pain. And one of the main ones I will get to in a minute, but there's one that you may not even know about, even the doctors in the room. Something like 10% of Caucasians have a gene, are missing a gene called CYP2D6, which is a gene that makes an enzyme that converts codeine to morphine. So if a doctor gave me that prescription and I were missing that gene, I would not get the pain-killing effects that I could otherwise, and I would probably get a lot of the side effects. But I guarantee that most doctors don't know about that. And that's 10% of the Caucasian population. That's a lot of people. And that's just one relatively trivial gene. Much more important gene is a gene called SCN9A. It's a sodium channel gene. And, ion channels let ions in and out of cells. And this woman, Pam Costa, was born into a family. It's a whole pedigree that's been researched. They have a mutation in this SCN9A, the sodium channel gene, it's called a gain-of-function mutation, which means essentially the nerve fibers that are transmitting pain are on all the time. They never stop firing. So she and the other people affected in her family, it's an autosomal dominant gene, so it's very prominent in her family. She's been in pain since the moment of her birth, and she will be in pain all her life. The only time in her life that she was not in pain was when she had her appendix out. She woke up in the emergency room while the anesthesia was still somewhat working, and she said, oh, this is what it's like to not be in pain. And she grew up in California. Excuse me. She used to walk to school in the gutters because there was water in the gutters. And one characteristic of this mutation is that you have burning feet. It's also called burning feet syndrome, and her feet were just constantly in burning pain. She would go home from school and sit around the bathtub with all of her cousins who had the same thing, with their feet in ice. And it was terrible. Let me just take a drink of water. This is a weird gene because she has a gain-of-function mutation, but there are also people like Ashlyn Blocker who was born with a different mutation in the same gene that resulted in a loss of function. So she's congenitally unable to feel pain, which might seem like a good thing, but obviously it isn't. She's broken bones and gotten burned and had terrible inflammations, and her parents didn't know what was going on. She actually went to the doctor once with a corneal abrasion. She was laughing and giggling, and the doctor said, something is wrong with this picture. Eventually she got diagnosed. That's a whole interesting story. But I said to her mother, well, at least when she goes into labor to have kids, she won't feel pain. And the mother said, yeah, but how's she going to know when to go to the hospital? It's very interesting. Anyway, the genetics is fascinating. So is the gender issue. There turns out to be a huge gender disparity in the chronic pain world. Women, girls to a little extent, but women, adults, have a bigger percentage of the chronic pain syndrome than men. We sort of have this myth that, men, have more pain than women, but it's actually not true. Women have a lot more pain. They're much more likely to have fibromyalgia, migraines, a lot of these chronic pain syndromes. And in fact, one very interesting thing, it hasn't been replicated as far as I know, but in adults, there was a study in Italy in transsexuals showing when they went from male to female and then they're taking estrogen, they have much more pain. And the ones that went female to male, they're taking testosterone, have much less pain. The whole estrogen thing is a nightmare. It's really complicated to figure out. Testosterone seems to be good in terms of relatively minimizing pain. Estrogen is all over the place. People's pain, like with migraines, it varies during a woman's cycle, whether you're pre or postmenopausal, and the data really conflict. Nobody really can figure out what's happening with estrogen. But they should. One of the big problems is that most pain research is not only done in rats, it's done in male rats, which is just stupid. And Jeff Mogul, my favorite geneticist, is sort of on a rampage trying to get researchers to use female rats. And it's basically just tradition and this sort of misguided belief that females are too complicated, you better study males, but that doesn't make any sense really biologically, and it certainly doesn't make any sense in terms of the epidemiology, because the females are the one who get more pain. Even in non-chronic pain situations, like when getting your wisdom teeth pulled, women have more pain right after that surgery than men, and no one really understands why. But the differences are big enough that my friend Jeff Mogul, who's not really my friend, but he's a nice guy, thinks that someday we're going to have pink pills for women and blue pills for men, that the differences are big enough. But doctors don't really take this into account. The other thing I spend, or not the other thing, another thing I spend a fair amount of time with in the book is the huge overlap between pain and depression. To some extent, anxiety as well, but the biggie is really pain and depression. And it goes both ways. If you're depressed, you're more likely to succumb to chronic pain. And that used to be the prevailing thinking, but now it's kind of shifting that the directionality is more seen as, if you have chronic pain, you're really at higher risk of depression. But it does definitely work both ways. And there was a fascinating experiment at Harvard and Oxford University in England where they induced depression, and while they were doing pain tests on people and putting them in fMRI brain scanning machines, and I couldn't resist sort of semi-replicating this. They played, for these volunteers, they played really depressing music. This is Prokofiev's Under the Russian Yoke, and they played it at half speed and had people read statements like, I'm a loser, life is terrible, nothing's ever going to get better, while they're doing all these pain tests with them and putting them in brain machines. And they rated their pain scores through the roof. Their pain was really high. Then they did the opposite condition. They played slightly cheerier music. This is Dvorak's New World Symphony. And they had them read positive statements, not even like, I'm great, but cherries are red, the sky is blue, kind of neutral to slightly positive. Same pain tests, same fMRIs, pain scores went way down. And this is not even real depression. This is fake laboratory-induced depression. So it's very interesting. And this does not mean that you're causing your pain. I mean, I wrestled with this chapter a lot. Just because there's an overlap doesn't mean that even if you're depressed, that it's your fault that you have pain. In fact, there's a brain scan showing that when you're in a bad mood, as on the left, your anterior cingulate cortex is activated, and when the same subject is in a good mood, that activation goes down. I have a long chapter in the book on the mind-body in pain because of this, exquisite overlap, and I go to great pains, as it were, to make clear that you're not caught. You didn't, it's not your fault if you have pain. But that said, you can do some mental tricks like meditation and relaxation and a whole bunch of hypnosis, non-pharmacological sort of mental things that can reduce your pain. And this shows up as effective in brain scanning and other tests. So it's definitely worth doing without blaming yourself that you're causing your pain. Exercise is another whole chapter and another huge remedy for many, not all kinds of pain. This is a woman named Susan Helmrich. I met her a couple of years ago. We were both swimming in the national championships that were in Mesa, Arizona. She's had 3 different kinds of cancer, and she showed me her scar in her stomach. Her abdomen was huge. And she is in fairly constant pain. We were having breakfast, and I said, what's your pain right now? And she said, it's 6. And for various reasons, she can't take any drugs. And here she is at the swimming meet.
The best master swimmers in the world have gathered in Mesa, Arizona for the U.S. National Championships, and 55-year-old Dr. Susan Helmrich is moments away from a major goal. Susan has plenty of determination, but doesn't have
my entire reproductive system, 1 lung, my gallbladder, my duodenum, half of my pancreas, and everything from my liver was rerouted. So literally, I have many, many missing body parts, and here I am.
Susan has battled back and beaten 3 very serious cancers to get here.
Okay, door mark.
Battles that began decades ago.
Swimming and training and goal setting and surviving really is what it's all about. And without swimming, I don't think I would have survived. I really don't.
She's an amazing person. But I've also talked to a lot of other people, including my sister-in-law, who I finally got to go to an exercise program. She has a number of pain conditions. And she wasn't in swim meets, but she was able to, instead of going to the mall and just being able to buy one thing, she could buy out the mall. So this is really progress in terms of pain control. Anyway, this whole talk is just an appetizer compared to the book. There's lots of things that I haven't been able to go into. I have some in the book about how cancer chemotherapy itself can cause pain, and there are some things you can do about it. As I said, a whole chapter on marijuana, which I found fascinating. A lot of stuff on the traditional Western treatments for pain, electrical stimulation, various injections, a lot of non-opioid drug things. In fact, one thing I forgot to mention in the opioid debate is we focus on opioids as painkillers as dangerous, but we hardly ever focus on the actually in some ways more dangerous NSAIDs and Tylenol, which people take like candy, and actually they can do a lot more, not more, but they can be very dangerous too. A lot of exercise, meditation, acupuncture, chiropractic, diet, and other things are in the book that unfortunately we can't go into today. So I'm just going to sum up. We have 100 million Americans in chronic pain. It's incredibly expensive. Medical schools do a terrible job trying to teach, not teaching people. The government does an even worse job. And in many ways, I've come to the conclusion that I first read about it in one of Dan's papers, but has been expanded upon since, that not only is pain control a fundamental human right, but that failure to do adequate pain control is close to a form of torture.
When I spoke to a human rights expert someone who has interviewed many individuals who've been tortured, and I said, well, you know, in your experience, how would you make this comparison? And he said, there is a real comparison. He said, for those who are tortured, he said, at least when you talk to them, they had periods of time that they were tortured, and then it stopped. He said, but for these patients that I saw with significant pain, there was no stopping. And there was someone who could stop it. You know, there was a drug available. It could be made available. It was available in some places in that same city. So why would I not call this torture to an individual?
I've come to the same conclusion. So my take-home message is pain management is really a fundamental human right, although we don't treat it that way. I've been a journalist for about 40 years now, and I have watched with great awe and respect as people with disabilities, people with AIDS, people with breast cancer have come out of their isolation and their stigma and their shame, and they've literally taken to the streets, they've taken to Congress, they've come into scientific meetings, and they've made their case that their pain, their problem should be taken seriously with serious money and serious attention. And I think it's high time for chronic pain patients to do the same. Thank you.
Thank you very much, Judy, for a tremendous overview that distills about 50 years and 10 PhDs into one book that I believe is accessible to the general public, but delves quite a bit into scientific dimensions. What I'd like to do now is to invite a couple of people up to provide perspectives and to ask that you may hold some of the questions until the end. And I'd like to invite Barbara Kivowitz, who has, as I mentioned earlier, just come out. It may not even be available, or it's just available in the last week, with the book In Sickness and in Health, because one of the things that Judy did not cover was the relationship between social dimensions of pain, including interpersonal relationships, and the physical fact of having pain. And then what I'd like to do is finish up with a former fellow of mine who was the outstanding fellow in his year of training and remained outstanding and has a tremendous experience with pain education, but is actively involved in clinical care, Zahid Bajwa, to provide a few perspectives and thoughts. And I'd like to open the floor to questions.
Should I sit there? Or?
Yeah, why don't you sit there? Yeah. So we have a couple of slides. I don't know when you want to show those, Barbara, but we're on cue. Okay. There's...
No. No. You didn't see that. So I'm Barbara Kibowitz, and I thank you for inviting me to be here today. And I'm speaking to you today. Can you hear me back there? I'm speaking to you today as a researcher, as a psychotherapist, and as a person who lives with a chronic pain condition. And what I want to focus on today is the social side of pain. Because pain, while it is inside somebody's body and it's a disease, like a stone thrown into a pond, it has a ripple effect. And it affects so many circles of social networks. And my particular focus is that first tier of the social ecosphere that pain affects, which is the couple, the person with the pain and the partner. So we interviewed many couples for this book, partners, surviving partners, and experts. And we did it because there were no resources out there to help us, to help couples, and the practitioners who were treating us understand how to manage pain in our lives. So both Roanne Weissman and I, my co-author, were the ill partners in our separate relationships. And Roanne suffered a stroke that paralyzed the left side of her body. And I, out of nowhere, probably through a combination of genetics and eating too much chocolate, came down with a chronic pain condition that literally took me out of life. I couldn't walk. I couldn't work. I was housebound for a year. And we were stunned by the staggering effect our pain, our illness had on our primary relationships with our partners. And we were also stunned by how important our partners were to our eventual recovery. And Roanne is now literally playing the cello. She's a health journalist. And I am here and back in life. So that's the good news. And I want to say, with no disrespect to anyone in this room, and with tremendous gratitude for everything that you do to help me and other people living with pain, I do want to tell you, in all honesty, that in order of healing power, first came my husband, that slide, or look at him right here. First came my husband, Richard, then came my dog, who had magical healing powers, and then came, it was probably about the 15th doctor I consulted. And I finally found a doctor who had the expertise to know what he was doing, who had the commitment to helping me get better, and who had the stamina for dealing with my ups and downs and my frantic phone calls. And I don't need a slide for that doctor because he's sitting right here, Dr. Daniel Carr. So I want to talk to you about couples and pain. And you know how pain affects your patients, but my guess is you don't know how pain affects the relationship. And believe me, it's not subtle. Pain immediately intrudes itself into the relationship and becomes the third partner. And it becomes the dominant partner. And what pain needs supersedes what the couple wants or needs. And pain determines whether you can socialize, whether you can travel, whether you can work, what you can eat, and how intimate you can be with your partner. And your world, the map of your world shrinks, and the touchstones of your world, which used to be very big, are now hospitals, clinics, doctors, and pharmacies. And in that narrow slice that's left to you exists you, your partner, your dog, your kids if you have young kids, and your doctor. And that's your world. And for the ill person, and this is important to understand, you suffer pain that's both physical and existential, and they're both incredibly severe. Your body has betrayed you, and your consciousness has been hijacked by pain. And the parameters of your thinking ability are now just more pain, less pain. Am I in more pain now or less pain now? And so your identity is really gone. And the person you were when you hooked up with your significant other is shrunk, is kind of gone. And you don't know who to become or how to get there. For the well partner, you are now in a relationship that you didn't sign up for. This was not what you asked for when you committed, but you're in it. And you feel resentment. And you feel resentment at the illness, and you feel resentment at your partner. And you feel guilty for feeling that resentment at your partner. And perhaps the worst feeling you have is a feeling of desperate helplessness as you watch your partner suffer and being tortured, and there's nothing you can do about it. And typically what happens is that what was once a relationship of equals with dreams about a future becomes a relationship of patient and caretaker. In addition, the old rules for running your life don't work anymore in the realm of the sick. You know, you used to work your job, and now your job has become working the pain and the medical system. That becomes pretty much your full-time job. And the conversations you used to have, you know, about weekend plans and going to the symphony and grocery shopping are now all about medication and medication side effects and what does our insurance cover and does not. And for many people, both the well and the ill partner still have to function in the world and have to work and have to take care of the kids. So the exhaustion is just immense, and the emotions are in a constant swirl of loneliness and fear and a little sliver of light and hope from time to time. I'm painting this picture for you just to give you a snapshot so that you'll understand the milieu that you're entering into when you treat the patient. The second thing I want to talk about is why should you care? Why should it matter to you, the relationship between the patient and her significant other? So for our book, we interviewed many people and their partners. And there were 2 vignettes that got replayed over and over and over again. One of them is that the patient and her partner are in the office with the doctor, and the doctor asks the patient, so how are you doing on this new medication that we've been trying? And the patient says, great, fine. And the doctor says, okay, well then I think we'll ramp it up to the next therapeutic level and see how you do. And the husband who's sitting there chimes in and says, what do you mean you're doing great? You're sleeping half the day and the rest of the day you're crying. That's vignette number one. Vignette number two is the doctor prescribes regular exercise, as you said, Judy, as an important part of the treatment. And the patient says, sure, and goes home and, of course, does nothing, doesn't exercise. Somewhere, somehow, he mentions to his wife that the doctor said he should exercise a little bit. The wily wife, a few days later, says to him, it's a beautiful evening, why don't we go for a walk around the block? That walk around the block becomes a nightly walk around the block, which then becomes a daily walk around the neighborhood and then a 5-mile jog on the track, at the high school track every day. So why should you care about the relationship and the partner? Because the partner is an essential source of accurate data. And the partner, I would say, is also the key to follow through on your prescription, on your treatment protocols. That's the short answer. The longer answer is that we are now in the age of patient-centered medicine, and nobody really knows what that means. And I would ask the question, when you're dealing with pain, what's the center? Is the center the pain or the illness? Is the center the individual in whose body the pain lives? I would suggest that you think about the fact that pain is a disease, and it's a disease that lives in an ecosystem, and that the center of the patient-centeredness when you're dealing with pain is the couple. And that's because while the pain resides in one person's body, it's two lives that are dislocated. And it's two lives, I can't do that, and it's two lives that are managing the pain. And if you're part of a couple, you know this. You are part of an intertwined, symbiotic system. And while the relationship may be generative or it may be destructive, it's still interwoven. And that's where the pain sits. And that's what influences the direction that the pain gets managed in. That's one reason. The next reason is support. If the well partner doesn't understand the pain and doesn't understand what you're doing to treat the pain and can't really help or participate, you are losing your strongest lever for intervention. In addition, pain, it's just too heavy for one person to carry. You need your partner to help you carry it. And if the partner starts to distance or to sink, the patient is only going to sink lower. So support is a very important reason. Here's a story, true story. It's in the book. One husband was sitting in the hospital hallway outside his wife's room, on the floor, silently crying, because his wife had just been diagnosed with pancreatic cancer the day before. A doctor comes by, sees him crying there, and says, oh no, no crying. You have to be the strong one for her. He felt kicked in the gut. He felt invisible and lessened. Imagine if the story had went this way, that a doctor came by, saw him crying, and instead said, "Of course you're sad and worried and afraid. And then I'll give you ABC, one of 3 other things to say." If that doctor had said, "How can I help you?" Or, "Would you like to talk to someone?" Or even, "Can I get you a glass of water?" That husband would have felt uplifted, would have felt recognized as part of this experience. And he would have taken that boost and then gone back into the room and been able to give that to his wife. We also heard stories about partners sabotaging the treatment. Many stories about the well partner who didn't like, whether for control reasons or caring reasons, didn't like the medication that the patient was taking, didn't like the side effects, and convinced the patient to lower the dosage or stop taking the medication. Judy, you talked about the overlap between pain and depression. And we interviewed one woman who had suffered a traumatic brain injury from a car accident. And her partner was toxic and accused her of malingering. Didn't believe any of her symptoms were real, accused her of malingering, and then said, if you were really sick, you would look sick. I don't know how many of you have heard the term invisible illness, but I just want to, I don't even know him and I want to slap him for saying that. And so of course she felt worse and increasingly depressed. And in hearing our stories about couples, I found myself wondering how much of the depression we see with pain can really be partially attributed to the couple relationship and what's going on there. I just wonder about that. The third reason you should be pay attention to the coupleness is information. Accurate information giving by the doctor and receiving by the patient and then acting on is treatment. It's imperative. And I can tell you that sorry Dan, but when I had an appointment with my doctor, I would remember maybe 20% of what he said for about 30 minutes. And that 20% that I remembered, I garbled because I was in pain, and pain distorts your thinking. Richard came with me to a lot of my appointments, and I counted on him to be my memory and to help me ungarble and retranslate so that I could act appropriately. The last reason is, and again, Judy, you talked about, this is so important, that depression increases pain. You need to hope. The patient needs to have hope. Hope is a medication, and hope and positive thinking. And I can tell you that as a pain sufferer, and having talked to many others, that we lost the directions to the land of hope after 3 months of being in pain. And a bad day was normal, and a good day was an aberration or even a scam that gave you a little bit of hope that was just going to be undermined by the next wave in your pain cycle. So I looked to my friends and my family and my husband to carry the hope. And there would be days when I would go to Richard or a friend, and I would say, can you tell me a hope story? Can you tell me a little bit about hope? So those are the reasons why you should think of pain as a social construct and the couple as the first tier to be paid attention to in your treatment. So I'm hoping that some of you are now at this point at least curious about what I'm talking about. What I'm really hoping is that I have persuaded all of you to think of the partner as part of the center and patient-centered. So if you do this, then if you believe me, then what can you do? What are some next steps that you can take? Well, at the time of making the appointment, ask your patient if she'd like to invite her partner into the session with her, number one. If the partner is sitting in the waiting room, then when you call your patient into your office, ask her privately if she'd like her partner to join. If the partner is not there and is not coming to appointments, then you can, in your session, ask your patient, how's your partner doing? And are you getting the support that you need from your partner? And best of all, if the partner is there and the patient wants him, I'll just use the masculine pronoun, in the session with her, then welcome him in. And at some point in the session, ask him how he's doing. And ask him if he has any concerns. Now, you may be thinking at this point, pardon my language, but screw this. I'm not a couples therapist. I don't want to be a couples therapist. I'm a nurse. I'm a PA. I'm an acupuncturist. I'm a doctor. I'm a specialist. I'm not asking you to be a couples therapist. That would be unfair to you, and it would be wrong because it wouldn't work. But what I'm asking you is to really take to heart and seriously that one of the most significant points of successful intervention you have is if you include the partner in the treatment. And I know for a fact that not all relationships are generative ones. Some are downright brutal and nasty, and the partner won't be of any help, but at least you'll know that, and you'll be able to factor it into your thinking. And if the couple needs psychotherapy, then luckily you get to refer them out. Thank you.
Judy's overview talk and now also Barbara's observations about couples.
And thank you, and I'm always happy to participate and have never said no to Dan Carr, the intensely sincere Dan. That's actually Tony Yaksh's original saying when we were in a flight. So a few things. I'm actually a citizen of the world. So Judy said it's a nation in pain. I would say it's a world in pain. And sticking with, I'm going to try to be brief and make a few points, and they may or may not connect directly, but they have meanings. I grew up in Pakistan and then spent time in England and then in New York and then have been in Boston for 21 years. And I do a bunch of charity stuff. So the positive message in all this is that when I first started going back to Pakistan and some other places to teach and see patients, people would line up and, there is no way to spend the kind of time and create order like we can here. But the worst of it was that I figured out what the problem is, but either many of those medications and treatments that we have available here, they're not available. And if they are, they're just so expensive So I came back and I would say, oh my God, we are so blessed to have all these things that are available here that are not available to a lot of others. What Judy said is really the point, that the education is what's lacking. And people's ability to recognize that pain in itself becomes a disease. And that's what needs to be taken into account, because our original model is that fever and pain and a few other things are symptom of something else. And you figure out that cause and treat that, and pain shouldn't be a problem. But if it stays, then you treat it like a disease. Now, thank God, our technology has come far away, and we have done it for a long time. But on to students for a moment, and Dan pointed out to, after I moved over to Beth Israel Deaconess, and Dr. Warfield and I started running the course Principles and Practice of Pain Medicine, and we have a book with the same title for professionals. I actually would have expected, and this was a national course which grew to a week-long course, I would have actually expected that more and more students would actually want to attend, and always had that thing that you can attend for free. Just let us know when are you going to be there so that logistics could work out. But, students not in large numbers took me up on that offer. And that was true of residents too. So I think somehow pain, headache, migraine, and I guess I'm, at least 50% of the clinical stuff I've always done has been headache, migraine, facial pain. Somehow we haven't created enough interest in students or residents, fellows to kind of pursue that, particularly in neurology. I was a neurologist growing up, and all my years at Harvard, from my fellowship till the end, and now I have an appointment at Tufts also, we actually didn't bring in many neurologists from within who would have an interest in becoming pain or headache doctors. I mean, that's a problem. And the third, last point on this, and then I want to have the opportunity for folks to ask questions, and that's, as a doctor, what makes me a good headache or pain doctor? And I think Barbara referred to some of those characteristics. So the doctor needs to listen and then be an active listener so that he can't let the patient or the partner or both kind of linger, and then interject and then give hope and give options. And the doctor has to be confident and feel there are options that have not been done before. Because a famous sentence that I have heard for a very long time from my residency days, that I have had these headaches for a long time and I've taken every medication, but I can't remember any, and even if I don't have time to tell you. It's your job to figure out what else needs to be done. So I think with kind of these mixed interesting things, so my job always is, number one, to find out, so what has been tried and how. And number two, keep an open mind. There are patients who have surprised me. I first met them and I thought, God, there is really no hope. And even an enthusiastic, cheerful doctor like me, thought, but I don't think this is going to go well. But 5, 6, 7 visits into, and me getting my hands on and offering them the nerve blocks injections along with medications and other things, they turn around. They do really well. So I think these are some of the things that make doctors good doctors, and I think Barbara and Judy both made the points of what makes patients good patients. So being activist in that role is good, but being enthusiastic, and I have said this to residents many times. I would meet a resident or a student and I would say, you have a good combination of compassion and compulsion to be a good headache or pain doctor. So compulsion as in OCD. So the healthy form of OCD is good for doctors and other care providers. And the second thing, which I had a line that fellows remembered over the years, that pain doctors need to be good copers, because they have to be able to cope with their patient's pain and not start to get depressed and say, there's nothing more I could do. And I'm just not going to touch the economics and social and insurance and cost issues on this, what play a role.
Can I just add one thing?
Please do.
In Johns Hopkins, the place that did the study about how little pain education happens in medical school, they also are trying a program to teach doctors, medical students about pain, and that includes, and I sort of hesitate to advocate this, but I kind of do, inflicting pain on doctors in the lab. And, experimentally, the pain could stop at any moment, not like a real pain patient, and they had the doctors or the med students keep, a diary of the whole thing and talk about it. And the students were blown away by their own emotional reactions to the pain. Because as I can attest, and I have a doctor in my book who is from Boston, you don't understand what severe pain is unless you've had it. I would never have believed that kind of pain could exist. It's so subjective and it's so off the charts that unless you felt it, you wouldn't believe it. And so there's a real disbelief problem. And at Johns Hopkins, they're trying to, inflict the pain. This is for 2 seconds, not for a lifetime. And the students had trouble with it, but they thought that was one of the most valuable parts of the program, was feeling it, because it is a sensation and it is an emotion. And I couldn't believe it. It was mind-boggling. And I think you really don't know it unless you've felt it.
Thank you. I don't mean to inhibit the discussion among the panelists. I think we could stay here and have the three of you bounce your insights off each other. But there is a little bit of time for some questions if people had some questions that they wanted to pose to our distinguished speaker and panelists. Carol?
I'm an occupational therapist, so I don't treat pain per se, but I'm interested in how patients cope with pain. Judy talked a little bit about the swimmer and she talked about setting goals for herself and the discipline of swimming. And it seemed that those things were important to helping her cope with the pain. And I wondered if any of you had, from all the people that you met and talked to, some generalizations about those people who successfully cope despite unremitting pain.
Well, I'll just say that the young woman in the video I showed, I think the physical and occupational therapy that she got, was key to her improvement. I mean, I didn't include that part of the clip, but she did get opioids, she got a lot of counseling, and she did a lot of physical and occupational therapy. And as you could tell, she got better. So, I just from that and my own experience, it really helps a lot.
And
for neck pain, please.
I would just add to that that I think those people who have hope and a loving support system are the ones who make the most progress. I think those are the two key ingredients.
And all therapy is important. So occupational therapy, neck pain suffer. I was rear-ended on Storer Drive a long time ago also, so I've experienced it. So that's where, posture and how you sit and how your work session is going to be and how you move this way and how long can you use computer and stuff. So I think that's the other message, that pain treatments need to be very inclusive because we don't have a lot of answers. We have a lot many more answers in America than we have in my native Pakistan, where I grew up. But we still don't have a lot of answers. So if acupuncture could help, herbal medicine of some sort would help, I think. So good doctors are open-minded about things that they haven't cured. Yes.
I think it's interesting in the age of healthcare reform and where we are right now, and having worked in pain management for decades, it seems to me that each patient needs an individualized treatment plan, and that may encompass a broad range of all of what you're talking about. The problem I see is that many insurance companies don't pay for the very treatments that certain patients need. So we need to figure out a paradigm shift of how do we get the right care to the right patient at the right time in a way that will be covered. And I don't think in the day and age of what we're seeing at this point in time, I think that that's where our system fails patients so terribly. Because it tends to be a sequential aspect of care instead of a holistic model of care. So do you have any suggestions or ideas besides the three of you getting out there and speaking to every medical school, the press in every state to talk about this issue, to give patients a voice, to let them know they're not alone, that they can advocate like breast cancer patients and others have, to make a difference? I mean, how do we really change the system?
May I ask just if you could restate that in a word or two because we're taping?
Me? Given we haven't talked about the insurance reimbursement thing. I mean, that's a whole nother pain. And we reimburse doctors for procedures as opposed to talking with patients. I talked to one doctor, Yoram Shur, who I think spoke here a while ago at McGill, and he has the best job in the world in terms of pain because he has a private source of money coming in from a foundation, plus that province in Quebec pays him to talk to people. He does fewer injections, fewer procedures than anybody else, and his patients get better. So we pay for the wrong stuff, number one. That's why there's so many injections and stuff like that. But I still keep going back to the medical education piece because one thing that's so expensive is that everybody ends up doctor shopping. I mean, it took me 7 doctors to get somebody to help me. So that's 7 visits. If the first one had had a more inclusive approach, that would have saved me a lot of pain and saved the system some money.
And I would just add that another dilemma or problem is that healthcare institutions are moving more and more towards standardization of care in order to save costs. And I think you're absolutely right on the money, so to speak, when you say that pain patients need individualized plans, which is the opposite of standardization. But I think another track, political track that's happening is evidence-based medicine. So I think the more that researchers, and many of the ones that you've met and that you've interviewed, can continue to do their research and show with evidence that differentiated treatment model is better for pain patients, that will have an impact.
We have a comment from Henry Klappholz. Yes, here.
I wondered what your thoughts are on, clearly we're not teaching adequately the medical profession, but society's role in this seems to be an important one. I don't think people respect pain the way they ought to. It's interesting, we just heard on the television the interview with someone who was a prisoner of war who was tortured and didn't talk and didn't say anything. And people look up to that. He tolerated it, he put up with it. And we often tell people to tough it out, don't be a sissy, that kind of thing. It seemed, I always wondered, I used to deliver babies, and there were people that didn't want any pain medication. They absolutely refused. And yet it became clear to me that they were being pressured by other folks, either their friends or their spouse even, under some circumstances. I remember the husband coming to me and saying, no, we had an agreement she's not getting any pain medication. We had an agreement. I wished I could make him go through labor a little bit, but it seems to me that's a very important thing, so I hope you sell 100 million copies of both of your books, because I think everybody needs to read this.
But also there's an intrinsic problem that language is inadequate to describe pain. The words don't, and David Birrell, one of the doctors I talked to, has written about that. I mean, the inadequacy of trying to put words on it. I mean, it's such a visceral experience, it's hard to convey, and then there's all the cultural stuff, and different cultures value, keeping it to yourself. And the other problem is that for women in particular, if you display too much emotion about pain, doctors diss you, everybody gets turned off, and doesn't believe you anyway. So it's really, how do you convey this without being labeled hysterical?
Well, I wanted to exercise my, I guess, chair's prerogative and first give a couple of shout-outs. The last commentator was Henry Klappholz, who's one of the deans, and the deans have enormously busy, crushing schedules. Not only was Henry here, but the dean of the medical school, Harris Berman, was here, and one of the executive deans, Marcia Samuels, was here. So they took time out of their really crushing, busy schedules to come and ascribe importance to everything you were going to say. And finally, last shout out is to our research assistant, Anna Schlissel, who put together a lot of the logistics and with an eye for detail, even ranging to the water, which turned out to be a crucial point. So we're very grateful to Anna, and we're also finally very grateful to all the students who came, both from our program and New England School of Acupuncture, and alumni who are also present, and friends. So thank you very much for a very stimulating afternoon.
Thank you.